Okay, everyone, we're going to talk about bed mobility now. And this lecture, I will preface this by saying that this will be much more meaningful as you have seen it in practice in real life. But for many of you, the kind of word by word descriptions may be helpful as well. So, bed mobility is basically either changing a patient's location in their bed or uh, basically getting prepared to come out of bed. And of course, it's going to depend on the patient's abilities. They can do this completely on their own with some assistance or with full assistance and or using equipment or adaptations. So those are all the movements that we may be helping a patient, scooting towards the head of the bed, down towards the foot of the bed, moving from supine to side lying and back, prone to side lying and back, and so forth, and supine to sit. So for many patients, same with transfers, after having undergone a surgery or a major illness or even a stroke or head injury, their basic functional mobility may be limited. And in these situations, physical therapy will get involved to try and improve or complete a return to independence. We've already talked about, that was my dog, sorry. We've already talked about positioning patients and the risk of skin breakdown and or a fixed joint limitation, otherwise known as a contracture. So these are reasons for bed mobility. So this acronym AMAP, as much as possible, ANAP, as normal as possible, this in many ways summarizes our approach to helping patients in the inpatient setting. We want to allow them to do all that they can do, and we need to avoid the temptation to do more for them than we should. So we want to maintain safety, but we want to allow the patient to do what they do, and we kind of make up the difference. So we want to help gravity, or allow gravity to help us. We also want to minimize friction so that we can protect skin. So if somebody is needing help with bed mobility, just like with the transfers, we want to explain what's happening and why. At times, adjusting the height of the bed or the angle of the bed can assist with what we're trying to accomplish. If someone is lying in bed supine and we're wanting to get them to, for example, move from the middle of the bed to the left side of the bed in preparation for a sideline movement, often we will do these movements segmentally. We'll have them first move their head to the left, and then sometimes they can walk their shoulders and then scoot their hips over. We'll try and help in any way that we can, but often breaking it down into components is easier for a patient. So after they have moved their head and their shoulders, then we can do the same thing with their hips and their feet. And sometimes this takes several steps to move as little as 8 or 10 inches to the side of the bed. But remember that all of these different parts of motions will often be the stepping stones to have the patient be able to return to doing this on their own. So another movement is a bridging type motion where a patient's lying supine in bed. We have them flex their hips and knees so their feet are flat on the bed. And then now they can push down with their legs to lift their pelvis. And sometimes we need to scoot the pelvis to the side. Sometimes they can do that on their own. But this is also helping them to use some of their key large muscle groups. This can be not only functional mobility, but can be a strengthening activity to help them overcome their deconditioning and get their endurance back. So sometimes patients, very often actually, patients will slide towards the foot of the bed. And so if they are sitting with the head of the bed up, for example, gravity will, over time, they'll start sliding down. So we begin by putting the bed flat, horizontal, or even Trendelenburg with the head below the feet. So now gravity can help them, or at least they're not working against gravity, to scoot uphill in the bed. And they can do that same bridging position where they flex the hips and knees, put the feet flat on the bed, push down, and slide themselves towards the head of the bed. So we as a therapist can position ourselves at the side of the bed, staggered stance, often athletic stance, and have our hands under the scapulae. Sometimes we have someone helping on the other side of the bed. Sometimes we're using a draw sheet. But in essence, as the patient pushes down with their legs and raises their hips up, we will make up the difference by assisting that upward motion in the bed. So same thing, if a patient's able to do this on their own, sometimes they're able to get kind of up on their elbows, use their legs, and complete the motion without any assistance from us. And so now if they're needing to move down in the bed, it's just kind of the opposite of what we just talked about. Sometimes we need to, again, change the position of the bed so gravity can help us, and we can help by raising the pelvis and sliding it towards the foot of the bed. Same thing if they're able to do it almost all on their own or completely on their own, we're just going to make up the difference. Now, when a patient's moving from supine to side lying, we need to be careful because side lying can be an unstable and dangerous position. We never roll a patient to side lying facing away from us, as the inertia can continue and they could roll right off the bed away from us, and we are not in a position to help them. So we want to have them move towards us. So we're going to have them move towards us. We're going to have them cross their arms over their chest, and then we are going to reach over the patient behind one scapula, our other hand on their pelvis, and help them by rolling towards us. Often the patient, if they have the strength, can reach towards us and grab the bed rail and assist as we are pulling them towards us. And now as they're side lying facing us, we are blocking the edge of the bed so they cannot roll off the bed. So similar idea, if they are able to provide a little more of the assistance, sometimes patients can, instead of flexing both knees up, as we did for the bridging type techniques, they can flex one leg up, and that helps them as they bring that leg across their body. That starts the rotation process, and then they can roll. We will demonstrate this in lab. So now supine to sitting is an interesting movement, and once again we're trying to get the patients to do as much as they can. So once they are in side lying, basically the motion we are striving for is to use the weight of their lower extremities as a counterweight. So we have them flex their hips and knees, and as the legs are coming off the bed, that's when we'll try to facilitate their trunk coming up and having them finish in a seated position. We need to use caution because we can generate inertia this way, and as we're helping their legs come off the bed, we will often with our other arm go underneath their shoulder or carefully under their neck, being careful not to use too much force on their neck, and then we help raise their trunk as their legs are lowering. So an alternative to the one motion where they end up dangling sitting on the side of the bed is this motion where we basically are helping them get into a long sitting position. So we will have one arm behind their shoulders and have them use their arms to help as they come into sitting, and then we can assess for dizziness. We've talked about orthostatic hypotension, which is triggered by a change in body pressure and the blood pooling in the lower extremities. So when we do this type of motion where the legs are coming off the edge of the bed at the same time as their trunk is coming up, we've gone from supine, completely horizontal, to now their legs are hanging completely down towards the ground, their body's upright, and for patients who are prone to it, the orthostatic hypotension can be triggered with this. So this motion here, just helping them come to long sit, can maybe be a middle step to assess how they're going to react. And obviously our goal with all of this is to help the patient to get to a point where they can do this all on their own. And so that's why all of these procedures are in place. We're teaching the patient how to position themselves and kind of use body mechanics and leverage to use the least amount of effort necessary so that as their strength returns, they can do it on their own. So that concludes our discussion about bed mobility. One final comment is that when we get a patient to this edge of the bed seated position, or otherwise known as dangling, on a hospital bed where their feet are not reaching the floor, this is definitely an inherently unstable position. What we have in the picture here is a patient with her feet on the floor, which is definitely stable. A lot of times in hospitals, the beds are quite elevated, and so we need to be aware of that. We never want to leave a patient unassisted on that edge of bed or dangling position as it is unstable. And that concludes bed mobility.